Hello, anatomy and physiology students, and welcome back to our third and final part of the respiratory system. Here we're going to look at some nervous system influences on the respiratory system, and then also some homeostatic imbalances. The idea is that this respiratory system, this simple thing called breathing, is actually a carefully and complexly sort of controlled, orchestrated system of rate, depth, and rhythms. So let's go ahead and look at how we might have a nervous control of breathing. Well, we see that some neurons in the brainstem of the brain are considered respiratory centers. So on looker's right, notice how we're going more in depth into the human brain, specifically this brainstem region. And we're going to have the medullary respiratory center within the medulla oblongata, and we're going to have the pontine respiratory center within the pons. And these are going to be regulatory nuclei that coordinate breathing. Together, the medullary center and the pontine center together are called the respiratory center. So let's look more in depth on how we might control respiration with these neural influences. We have two main factors that influence the rate of breathing and the depth of breathing. And that's going to be getting input from higher brain centers. We're talking about the cerebral cortex. Notice how that's coming into our respiratory center. And then also we get chemical factors. Things like peripheral chemoreceptors come into this respiratory center, receptors in muscles and joints, irritant receptors, stretch receptors. These are all coming into this respiratory center. So let's take a closer look at now this higher brain center. So this higher brain center, recall, is part of the cerebrum. It's a cortical influence. So we're talking about voluntary control. On looker's right, notice how we're talking about the primary motor cortex. Students from the last semester might remember that this primary motor cortex is going to innervate skeletal muscle. So that means the cortex of the human brain has conscious control of respiration, and that may be needed if we want to avoid inhaling any noxious gases or possibly any water. So we can voluntarily indeed hold our breath, but to a limited degree. That's limited by the overriding stimuli of hydrogen ions and carbon dioxide. So basically, if you hold your breath all the way up until you faint, then breathing will resume and take over. In addition to higher brain centers, we have chemical factors. Generally speaking, nerve signals from the respiratory center create a rhythm of about 2 seconds of inspiration and about 3 seconds of expiration. The average range rate of quiet breathing is going to be about 12 to 15 times per minute, and you might recall from the last segment we call that eupnea. Well, we have sensory input from receptors. That's going to be sent to this region of the brain, and that's going to relay information to change the rhythm of the breathing and the force of that breathing. So we have central chemoreceptors that are located in the medulla, and it's going to monitor pH changes. Specifically, we're looking at pH changes of cerebrospinal fluid, and that pH change of the CSF is going to be caused by the partial pressure of carbon dioxide. In addition to these central chemoreceptors, we have peripheral chemoreceptors, things that are in like the aortic body or the carotid bodies. These are going to be housed, these peripheral chemoreceptors are going to be housed within the walls of these blood vessels. And I think we talked about this earlier. These carotid bodies are going to be located at the split of the common carotid artery, and the aortic bodies are going to be housed in the aortic arch. These peripheral chemoreceptors are going to detect pH changes in blood and also changes in blood respiratory gases. These receptors can be stimulated by pH changes independent of the partial pressure of carbon dioxide, where central chemoreceptors cannot. So these chemoreceptors are going to be much more sensitive to changes in the partial pressure of carbon dioxide than to changes in the partial pressure of oxygen. So that's kind of neat that some students realize that we're mostly responding to changes in carbon dioxide in the human body, in other words, a waste gas, and not so much the changes in partial pressure of oxygen, which is sort of the desired gas. It's noteworthy that in addition to these chemical factors, we're going to get proprioreceptors. That's going to relay signals to the respiratory system, respiratory center, in response to increases in body movement. So you might recall these proprioreceptors are sometimes located within joints and muscles. And then we also have baroreceptors. Those are going to initiate a reflex to prevent overstretching of those lungs by inhibiting that inspiration. We sometimes also call that the inhalation reflex. And just as a side note, it's worthy to note that the hypothalamus increases the breathing rate if the body is warm, and then that hypothalamus is going to decrease the breathing rate if that body is cold. And in addition, the limbic system can also alter breathing rate. That's in response to emotions. So as we just mentioned, the body is particularly interested in monitoring the levels of carbon dioxide and adjusting accordingly. So we want a sort of homeostasis, a regular balance of partial pressure of carbon dioxide. Like most homeostatic balances, it uses negative feedback regulation. So we do use the negative feedback control of breathing. So with an increase in the partial pressure of carbon dioxide in the arteries, well, that's going to stimulate receptors, and that's going to be sent to that inspiratory center of the medulla oblongata. Then the muscles of respiration are going to contract more frequently, more forcefully. We're talking about muscles like diaphragm and external intercostals, and that's going to cause a decrease in arterial partial pressure of carbon dioxide, but that's going to cause an increase in pH and also cause an increase in the partial pressure of oxygen. So again, the human body is always trying to find this homeostatic balance day in, day out. As we speak about homeostatic imbalances, we might lead to two possible other ones, respiratory acidosis and respiratory alkalosis. Respiratory acidosis is in reference to a low blood pH and low bicarbonate levels. This could be the result of slow breathing or possibly a disease like pneumonia or emphysema. What's happening is a high partial pressure of carbon dioxide could result in this decrease in pH, and that's because as the carbon dioxide increases, a certain chemical reaction occurs, and the result is we get a lot of hydrogen ions. And the greater percent of hydrogen ions, we have something that's more acidic. So hence the respiratory acidosis. Also, we might get respiratory alkalosis. In other words, high blood pH level, blood moving towards something that is more alkaline. And so this occurs when CO2 is eliminated from the body faster than it is produced. A good example of this is going to be hyperventilation. So therefore, a low partial pressure of carbon dioxide can possibly result in a decrease of those hydrogen ion concentrations in the blood. And so how might we maintain this homeostatic balance, so to speak? We have a bicarbonate buffer system, and students might have to reach out into other chapters to track down reading on the bicarbonate buffer system, such as chapter 25 in the McKinley textbook. And so once again, we're using an acid-base homeostasis to have a nice proper pH level of the bloodstream. And so we have two key components of this bicarbonate buffer system. We have the bicarbonate ion, and that's going to serve as a weak base. And then we have carbonic acid. That's going to act as a weak acid. So we want to maintain a relatively constant pH in the plasma, and we want to counteract if any additional acids are added or any additional bases are added. So for example, if we add extra acid to this situation, the bicarbonate is then going to bind the excess hydrogen ions, and it's going to create a weak acid H2CO3. When the opposite occurs, if we add a base to the situation, then the weak acid H2CO3 is going to release those hydrogen ions. And as it releases those hydrogen ions, we are able to correct the pH and bring it as to a more balanced level. So in summary, in this bicarbonate buffer system, a strong acid gets buffered to produce a weak acid, and a strong base gets buffered to produce a weak base. And again, we want to maintain a proper level of homeostatic balance of the pH inside that blood. Let's now turn our attention to respiratory adjustments. These are not homeostatic imbalances, but how might respiration or breathing be affected by the following influences? And the first one we talk about is exercise. So this respiratory system is going to work along with the cardiovascular system to make sure we have proper perfusion for different intensities of exercise. So let's take, for example, the graph on the right. Notice we have breaths per minute on the y-axis. In a resting period, we're talking about the usual around 12 breaths per minute we've been discussing. Perhaps jogging after about 30 seconds is going to raise those breaths per minute, approximately 20. Jogging vigorously after 1 minute is going to raise that breath rate even further. So what's happening here is that muscles are using up that oxygen. And so we're going to have blood flow with a lower amount of oxygen and a higher carbon dioxide content. The lungs then pick up for this, and they adapt by matching this with increased ventilation and also increased oxygen diffusion capacity as more of those pulmonary capillaries open. So neural factors are going to increase this ventilation, and it's also noteworthy that during exercise we can make a respiratory adjustment while also breathing more deep as well. Another influence on respiration is smoking. Much of this research we talk about is in reference to smoking tobacco. And we might say that smoking sort of blackens these respiratory passageways. We can see that on the lower right. And also causes respiratory changes that increase the risk of respiratory infections and damage that may possibly lead to emphysema or lung cancer. So we might see that a person who smokes frequently is going to be quote-unquote easily winded, perhaps. Nicotine has the effect of constricting terminal bronchioles. Carbon monoxide is going to affect the hemoglobin. Irritants cause excess mucus secretion. Sometimes we get, example, smoker's cough. A person might cough first thing in the morning. That's the cilia kicking into gear and sort of moving that mucus out where it needs to go. So smoking is definitely going to have an influence on respiration. Another influence on breathing is going to be being immersed in a high altitude. On the lower diagram, we see different oxygen levels. Notice how oxygen levels varies with elevation. So perhaps if you're sitting out here in Anchorage, the bowl of Anchorage, you've got sea level roughly about 100% oxygen. But let's say if we took a drive up the Parks Highway and made our way up to Denali National Park and perhaps summited Mount Denali, we might see the peak at 20,000 feet only has half as much oxygen as we might find in sea level. So then, that could sometimes lead to imbalance. Acute mountain sickness might occur over 8,000 feet. So this altitude sickness is going to generally refer to any sort of adverse physiological effect because of a decrease in the alveolar partial pressure of oxygen. We're talking about things like headache, nausea, difficulty sleeping, pulmonary edema, and cerebral edema. How might we adapt to this? Long-term exposure. Long-term exposure will lead to acclimatization and also EPO production, erythropoietin hormone. Another influence on respiratory adjustments is aging. Respiratory tissues and chest walls do become more rigid and stiff with time. Our vital capacity decreases. Macrophages become less active. Those tiny little hairs on the edge of the cells called cilia, those reduce in their action. And we have a general overall decrease in levels of blood oxygen. So because of this, we might get more susceptible to conditions like pneumonia or bronchitis as we age. Let's run through some other homeostatic imbalances here. Let's talk about one called pneumothorax. We had discussed this one earlier. And as we said earlier, pneumothorax occurs when air gets into the pleural cavity. So these pleural cavities are serous membranes. They're supposed to be sealed cavities and not open to the outside environment. Injuries to that chest wall can penetrate those pleural cavities and let air enter into that intrapleural space. So we might get a sort of collapsed lung, as shown in the diagram on looker's right. And that lung might collapse because of surface tension and recoil of elastic fibers that causes those alveoli to stick to one another. Another homeostatic imbalance is asthma. Asthma is a chronic condition shown by episodes of bronchoconstriction. Those tiny bronchial passageways become constricted. So we might have things like wheezing, coughing, shortness of breath, and excess pulmonary mucus. Asthma typically develops when a person develops sensitivity to an airborne agent, such as pollen or something, and localized immune reaction occurs in these bronchi, and the bronchioles re-expose themselves to this triggering substance, causing these asthmatic attacks. So in this diagram, we see a normal bronchiole as compared with an asthmatic bronchiole. So common triggering factors are going to be allergies, but interestingly, even emotional response or getting upset can also trigger an asthma attack. These episodes typically last for an hour or two, And a good treatment for asthma is to administer a type of steroids. These steroids are given, they get inhaled through a sort of inhaler. And that inhaler is going to reduce the inflammatory reaction. And in that inhaler, there's also going to be bronchodilators to alleviate that bronchoconstriction. Another possible prevention for asthma might be simply to get allergy shots. Another homeostatic imbalance that we mentioned earlier would be hypoxia. The name kind of says a lot about it. Hypo being less of, oxy being oxygen. So hypoxia is a decrease of the partial pressure of oxygen, and that's going to be due to the lower amounts of oxygen diffusing from the alveoli into the blood. Another disorder we encounter might be chronic obstructive pulmonary disease. This is a type of respiratory disorder characterized by chronic recurrent obstruction of airflow. Let's look into a couple more common cases of COPD, that is emphysema and chronic bronchitis. Emphysema is going to be a condition in which the walls between the alveoli or the air sacs lose their ability to stretch and recoil. Early symptoms of emphysema are going to include shortness of breath and coughing. And this emphysema is an irreversible loss of pulmonary gas exchange surface area due to inflammation of those air passageways and therefore widespread destruction of pulmonary elastic connective tissue. So this emphysema is going to lead to dilation and fusing together of the alveoli, and therefore we're going to get a decrease in the surface area. So therefore this lack of surface area then leads up to a buildup of deoxygenated air in the lungs. Causes of emphysema, in most cases, are caused by smoking tobacco, and emphysema that's not linked to smoking is usually caused by a genetic disorder. Another form of COPD is going to be chronic bronchitis. Bronchitis is going to be termed as an inflammation of the bronchi, and this inflammation can be caused by a viral infection, perhaps a bacterial infection, maybe inhalation of irritants, or again, cigarette smoke could trigger this. Acute bronchitis develops rapidly and resolves itself within about 10 to 14 days. And this chronic bronchitis is going to result from long-term exposure to irritants, and that's going to also be characterized by a large amount of mucus being produced, and then also a cough that lasts a long time. Yet another homeostatic imbalance of the respiratory system is going to be bronchogenic carcinoma, in other words, a type of lung cancer. Lung cancer occurs when epithelial cells become replaced by cancer cells. And this lung cancer is a highly aggressive and frequently fatal disease, and that's going to originate in the epithelium of the respiratory system. Again, smoking causes roughly about 85% of all lung cancers. Symptoms of this cancer include chronic cough, or perhaps coughing up blood, excess mucus, and also more higher frequency of pulmonary infections. This metastasis often occurs early in lung cancer, making a surgical cure unlikely. This squamous cell carcinoma is going to be the most common form of lung cancer, and healthy lifestyle changes such as quitting smoking can help prevent this lung cancer. Other smaller homeostatic imbalances include a pneumonia. Pneumonia is an acute infection of the alveoli. Typically, it's going to be bacteria that cause this infection. We can give antibiotics. It's going to be the number one way to treat this pneumonia. Bronchodilators, oxygen therapy is going to help prevent and cure pneumonia. On a lesser degree, we have coryza, the common cold, the rhinovirus, in other words, is going to be caused by a virus, usually not accompanied by a fever, whereas the influenza is actually a virus that's usually accompanied by a fever greater than 101 degrees. That's one of the greatest killers, or greater killers, I should say, of humans besides war, has been the flu, influenza. And we leave off today talking about tuberculosis. That's going to be an inflammation of the pleura in the lungs. So this inflammation of the delicate membranes around the lungs is actually caused by a bacteria, and therefore it is communicable. It can be spread. We can prevent this through vaccinations of tuberculosis, and we can see from this map in the lower right that in the Western world we have dramatically reduced levels of tuberculosis, but still 1/3 of the world is infected by this common respiratory malfunction, where lung tissue gets destroyed permanently, leaving a non-functional fibrous tissue in its wake. So that does it for the respiratory system. We talked about some homeostatic imbalances and some nervous control. Thanks for your attention. Jump in the next section where we're going to talk about the digestive system on our next segment. Good day.